of affordable anti-VEGF drugs. The background is diabetes mellitus. A survey of NPCB visual impairment done in 2015-19 showed a prevalence of diabetic retinopathy, repeated injections of intravitreal anti-VEGF injections, which are unaffordable to most of our country's population. So our aim and objective was to develop a replicable and sustainable eye care delivery model to ensure affordable, timely, and accessible care to all diabetic retinopathy patients in Thrissur district, to involve both public and private institutions providing retinal care and supervised by the District Ophthalmic Club. So the first phase in 2019-20, the Thrissur DOC started a community outreach program called the Tako Deepam, and the main project of this initiative was the Diabetic Retinopathy Evaluation and Management Mission, or the DREAM mission. The first phase conducted diabetes detection camps. We did educational programs. We conducted physician organizations in the district to refer diabetic patients. And the final evaluation was done in the DREAM clinic by both the community medicines and the DOC members from both private and government institutions. And the observations which we found was that there was poor eye health seeking behavior among diabetes patients, low knowledge about diabetic retinopathy causing blindness, poor access to trained retinal specialists, and inability to afford anti-VEGF injections. So the DREAM phase 2 was started, where we developed an eye care model. The DOC held a series of meetings with institutions which provide retinal care, and various models were discussed and finances were discussed. And this led to the development of a public-private cooperative model based on the concept that one multi-dose injection of Avastin can be subsidized for 10% of patients in 1 month. So we developed a Tako Deepam website, and 6 private ophthalmic hospitals registered their services here. And the key components of the model was that the initial screening was done by the ophthalmologist at the first point of contact. If the need was an intravitreal injection was felt, a free macular OCT was done from the government medical college, and then the patient registers at the website page. He can choose the hospital, upload the report, and which goes via email to the institution. The institution will contact the patient, fix a free OP appointment, and subsequent delivery of subsidized anti-VEGF injection at mutually convenient dates. The DOC, or the District Ophthalmic Club, is not to be held responsible for any lapse of service, which is the sole responsibility of the hospital providing the injection. And through the portal, patient can access educational material and other social services. He can interact with office bearers. So the results of this phase 2 was July 2021 to 23, 512 registrations from 423 patients were received. 63% were males, and the ages ranged from 26 to 82 years with median age of 62 years. Though there were many indications, 86% of patients were referred from government institution, and diabetic retinopathy was responsible for about half the referrals. The accessibility issues, the website encountered access issues during 2 periods. The first one was in July, where there was a re-registration of the website, and in December, where a change was required in the calendar settings. However, patients were able to contact the DOC admin through the email option. The advantages of the model: it used friendly software. The registration form could be accessed on mobile. Daily registrations were received by admin through mail, and it was highly cost effective and less slow maintenance. The advantages of the service delivery: patients received appointment within a week and given standard but subsidized care. Easy scheduling of subsequent follow-up was done, and issues could be easily sorted out. All participating institutions saw an increase of patients in their retina practice. But some of the disadvantages: that elderly patients required help for registrations, smartphone was needed for access, and technical support was needed for maintenance of site. And so the present model built by the DOC fulfills all the criteria of an effective community intervention model. It addresses community needs, understands its constraints, provides easily accessible, affordable, and evidence-based care, generates health-seeking behavior, gives a digital report for the entire district, and advantages to all participating institutions. And the DOC supervision as an organization is best suited for coordinating and monitoring the activities. It provides an insider's understanding of the community. It can tackle implementation difficulties. Finances and costs are open to scrutiny, and other social networks or activities of the DOC get publicity. So the same kind of a discussion was done by Bhusnoor Math, who discussed a hospital-based community eye health program as a sustainable model without creating permanent posts. All recurring expenses like consumables, spectacles were absorbed by the hospital as part of their regular annual budgets. Our Tako Deepam model too is hospital-based, ensures subsidized and coordinated clinical care with minimal costs and no liabilities to the DOC. Thus, our project is also sustainable. District clubs can therefore play a pivotal role in providing a common platform for collaboration in public health initiatives. Effective community ophthalmology services can be provided by a spirit of cooperation, inclusion of both public and private comprehensive eye care providers with freedom of choice regarding the provider and schedule ensures active participation of the individual, and all institutions participating receive recognition and goodwill, which will provide long-term benefits. These are my references. Thank you.
This website and the sponsor, who is sponsoring the upkeep of this website
The
as far as
DOC.
DOC only?
Yes.
From their own income, they are doing it as
Yes.
a
Yes.
charity
Yes.
activity.
Mm.
Okay.
We have some fund for it. So
Approximately, what is the monthly or yearly cost?
the yearly cost actually for this initial cost was 40,000. Then the maintenance was 3,000 every year. For that thing you have to maintain.
How do you advertise that this is happening to the DR patients? You go through hospitals who are taking care of DA or directly
They
patient?
get a call. They can choose the hospital. They get a call, and then when they get the call, they can select the time they want
Okay.
to get the injection, and that time is between the two people, the hospital and the.
So the government is not directly involved in this anyway.
No, government is not acting. The point is that if on a single day you can give injection Avastin for 10 people, one of it can be subsidized.
Correct.
That is the main thing. So that is the advantage which we found for this model, and it helped them.
Great effort.